Good morning. We're going to do RWJ team first, and then the rest of the guys will jump in one at a time. First patient is a 61-year-old female who fell down the stairs and was found down in the basement with a C5 bilateral lamina and spinous process fractures. She was intubated on arrival due to a subdural hematoma with a 8mm shift. She's still unexaminable and remains intubated with a guarded prognosis. So she's just in an aspirin collar for now. This is a 43-year-old female who slipped in high heels and sustained this T12 and L1 compression fractures. She was given a TLSO brace. This is a 64-year-old female who lost control of her vehicle and hit the median and has this T12 burst fracture. She was neuro intact and given a TLSO brace. This is a 58-year-old male who presented with a first-time seizure and was found to have an L3 compression fracture. It was thought to be post-viral in nature. He was neuro intact and given an LSO brace. This is an 85-year-old male who fell at his assisted living, had this isolated left greater trochanter fracture, periprosthetic, that appears well fixed. He was made protected weight bearing with a walker. This is a 70-year-old female status with fall with a left tibial plateau fracture. Underwent CAT scan and then underwent tibial plateau or AF. Next patient is a 37-year-old male status with fall with a left pathological femur fracture. Patient previously known to our service with left knee septic arthritis and left thigh abscess, status was multiple INDs. He was on IV antibiotics. About 2 weeks later, he was getting on his pants. He put all of his weight on his left leg and he felt a snap. This is MRI from the previous admission, showing osteo. He underwent left femur antibiotic intramedullary nail. There were some antibiotic beads inserted. The 52-year-old male status post fall from a ladder with the right ankle and talus fracture. Underwent CT scan. Initially was X-fixed due to swelling, and underwent left talus and ankle ORAF.
John, can you go back to the, I'm sorry, can you go back to the intramedullary nail and just explain what's happening there and what the theory is? I'm just not familiar with that construct.
Sure. Okay, so this guy has osteomyelitis in his femur. So we basically did an antibiotic intramedullary nail. So there's antibiotic bone cement surrounding the nail. We reamed up to about a 16 and inserted the nail. And there's these antibiotic beads kind of over here. So it's just delivering some more antibiotics locally to treat the osteomyelitis. So eventually, we'll exchange this nail. There's kind of this area that we resected here. Around where the fracture was, we resected some necrotic bone, and we're eventually going to remove the nail, exchange the nail, and bone graft.
Why did you? And what about that cerclage wire? Sorry.
Yeah, so the reason for the cerclage wire was, when the nail was being passed into the proximal fragment, it developed a longitudinal crack, so we cerclaged it. Patient's strictly non-weight bearing at this point, given his bone quality and given the fracture.
Why do you retrograde that nail, and why do you have to open it?
Why did we retrograde the nail, and why did we have to open it? So the the patient underwent, 8 INDs before this fracture. So he had an incision, he had an anterior incision on his thigh, and we basically reopened the incision that he had for the INDs. And, what we found is that he had some pus, within the thigh, so we IND'd it again. We kind of resected some of the necrotic bone around the fracture site. And, that's basically why we did it, because we were doing another IND anyway. So it was already open.
So the femur had 8 INDs for an osteomyelitis?
For an abscess. So he had like a chronic abscess, which, then developed into septic arthritis. Yeah.
What's the organism?
His organism was Klebsiella.
Again, I'm not familiar with this, but it looks like you have some cement there between the 2 fracture ends. So there's like no way that this will heal. So you're almost obligated to come back a second time.
Yeah.
But,
yeah, that's
but
what the plan is.
Is it right? But is it worth the chance of, you have all those antibiotic beads there. Is it worth it to get some compression at the fracture so there is a chance that you don't have to come back? Or is this, it has to be kind of in that area?
Yeah. So he's already shortened by, about 5 centimeters. We're essentially doing like a masquelade technique here, to try to preserve some of his length.
John, he can't walk on that nail, right? That nail's an antibiotic nail. That has to come out, doesn't it?
Yeah, this antibiotic nail is going to have to come out. And he strictly is non-weight bearing now because the quality of his bone is so poor from this osteomyelitis. And also the intraoperative fracture didn't, help his weight bearing status at all. But, so those are the main reasons.
And what makes a nail an antibiotic nail?
It's the nail's coated with antibiotic cement. So that's what makes it an antibiotic nail.
How did you know in advance it was dead bone?
What was that?
How did you know in advance that he had all that dead bone?
Oh, because so we had done multiple INDs on this guy, and just kind of looking at his X-rays. The bone quality is very poor.
No, I didn't ask the quality of the bone. I asked, how'd you know it was dead bone? What kind of bone gets removed? Living bone or dead bone? For osteo.
Dead bone.
So I'm asking, how did you know this was all dead bone that you removed?
It was opened and we visualized it. It was non-bleeding bone.
Does anybody know why 8 INDs in antibiotics for I don't know how long didn't work? I mean, that's kind of, I know it's a weird organism, but if 8 INDs and how many weeks or months of antibiotics did he have before he broke?
He had about 2 weeks of IV antibiotics before he fractured.
So you had 8 INDs within 2 weeks. That's a lot of INDs.
Yeah. No, so the INDs were over the span of 2 weeks in the hospital, and then after he was discharged, he had about 2 weeks of additional antibiotics, making about 4 weeks total of antibiotics.
All right.
He has hepatitis C. He's a heavy drug user. So
Yeah, doesn't look good.
Hey, Stelmach, when you made that antibiotic nail, did you coat the entire nail or did you just coat between the distal and the proximal interlocks?
I believe it was between the distal and the proximal interlock.
Yeah, the only thing you have to be, we actually do a lot of those out here. And the one thing you got to be careful about is if you coat the whole nail, you have to take your ball tip guide wire and you have to keep cannulating the nail as the cement sits, because the cement will leak through your interlock holes. And then if you don't do that, you'll go to put that nail in over the ball tip guide wire and you'll find out you have dried cement or hardened cement in, and then you just burned the nail. But yeah, no, we do a lot of those out here, different techniques. unfortunately, it's not a great situation. A lot of these don't really get better. So
This is a 40-year-old female, status post motor vehicle collision with a right femoral neck, as well as a femoral shaft fracture, ankle fracture. It's the same side. Initially placed into a splint. She underwent right ankle ORIF, deltoid ligament repair, and she was found to have a ruptured PT tendon. So that was also repaired. She then underwent a retrograde femur nail and a DHS. She was in a sloppy lateral position.
Right. I don't know if that's a DHS.
Yeah, it's just
that looks like a femoral neck system, or a kind of is that Smith and Nephews, or is that a Synthes?
it's a Synthes femoral.
Yeah, so that's the FNS system. It's kind of like a modified DHS type thing where there's 2 screws. You can use that for basically your basic cervical or non-displaced femoral neck fracture, the valgus impacted. It's a big Synthes house over here, so we use that a lot. It's a good construct.
And what was the reason for the deltoid ligament repair?
So it was torn and opening up medially. So there
Is that something that you guys are commonly doing now that's just not typically the way I remember it?
Yeah. So this. Yep. So there was. Sorry, I should have mentioned this earlier. There was an opening medially, and you could see the PT, the posterior tibial tendon, was ruptured, and as well as the deltoid ligament. So those were repaired.
Where was the tibialis posterior ruptured?
It was ruptured just proximal to the tip of the medial mal.
How was the rest of the neurovascular bundle?
It was intact. Yeah, everything was intact other than the posterior tibial tendon. Next was a 37-year-old male, status post assault, the left ulnar shaft fracture, direct blow injury, closed neuro intact, placed in a sugar tonic splint. Follow him non-operatively. Next is an 8-year-old female, status post fall with the right both bone forearm fracture. She was closed reduced and placed into a sugar tonic splint.
Uh, 54-year-old male who's in an MVC. He has a right distal radius, left distal clavicle, and LC2 pelvis fracture. He was closed reduced and put into a sugar tonic splint on the distal radius, sling on the left for this clavicle. And was made weight bearing, tolerated, and taken post weight bearing X-rays, which showed the pelvis was stable, so he was treated non-operatively. Projected weight bearing on the left. Next is a 10-year-old male with a skiffy. He was taken back the next day for a.
Speak up a little bit, please.
Next was a 10-year-old male with a subacute skiffy. Was taken back for a percutaneous spinning inside too.
How come you didn't pin his other side?
It was discussed with the mom. I mean, he's 10, so he's kind of right on the border. And so she kind of elected to kind of watch him non-operatively and close follow-up.
How often do you have to consider pinning both sides?
If they're under 10, it's fairly frequently. I think 10 is usually the cutoff. So I mean, I think they slip about 50% of the time. So you just close follow-up.
Probably has more to do with their skeletal maturation. And there's a number of things you can look at to determine their skeletal maturation, like their Risser sign, the ossification of the greater and lesser trochanters, but probably most importantly is the triradiate cartilage. But I think in this community, I think that unless they are very skeletally immature, or unless they are syndromatic, or have issues where they're more likely to slip the other side, we'll counsel the family and kind of, only do one side.
Good morning. First patient is a 46-year-old female. She was an unrestrained passenger in a motor vehicle collision, was polytrauma, trauma alpha. There was another person in the vehicle who died in the accident. She presented with a right open subtalar dislocation, type 3 by mechanism, was about 4 centimeter lateral opening. She had a right scapular body fracture, non-displaced, a left proximal humerus fracture, a right LC1 pelvis fracture, and a T4 3-column spine injury. She had no motor sensation below the level of the nipple. This is her scapular body fracture, as well as her, she's more like a greater tuberosity fracture, minimally displaced. Pelvis. CAT scan of her thoracic spine. As well as an
What was her
MRI.
age of classification?
So she's still in spinal shock, but she would be classified as a T4 Asia A if she does have a bulbocavernosus reflex. She does not have one yet. Her subtalar our dislocation was reduced in the trauma bay and then was taken the following day for an IND, a closed reduction and splinting. And then the day after that, she went to the operating room for a T2 to T6 posterior spinal fusion.
What was the classification of her fracture of the spine? What kind of fracture was that?
So it looks like to me, it's kind of, I think it's a little bit like a flexion compression type fracture, but it almost also looks like it could be a little bit of like a bony, it's really a burst. I mean, it's a flexion compression like burst fracture. So she's currently, like I said, still in spinal shock, but she's doing relatively well. She's currently post-op day 1 from her spine. Next patient is an 18-year-old female, status was mechanical fall. She presented with a right type 1 open distal femur fracture and a right distal radius fracture. The distal radius was initially closed, reduced, placed into a sugar tongue splint. X-rays of her femur fracture, which had a very small poke hole over the anterolateral thigh. CAT scans are obtained of the distal femur fracture. And she was medically optimized and taken the following day for a right femur ORIF and IM nail as well. And we decided to fix her wrist. It was an acceptable reduction, but just for purposes of allowing her to weight bear through her forearm, we fixed her wrist with a distal radius ORIF. Next patient is a 71-year-old male, status was mechanical fall. He presented with a left femoral neck fracture. He is severely demented and minimally ambulatory. He was taken the following day for a left hip hemiarthroplasty. Next patient is a 58-year-old female, status was slip and fall at home, presented with his right trimalleolar ankle fracture. She was initially splinted, closed reduced and splinted, and then was taken the following day for a right ankle open reduction internal fixation. Thank you.
Morning. This patient is 86-year-old female, status was full with
left subtrochanteric pathological femur fracture. Patient was taken biphosphonates. She was found out with peaking on both sides. She was taken to the OR for left femur intramedullary nail. Next patient is 91-year-old female, status was fall with right femoral neck fracture. She was taken to the OR for right hip hemiarthroplasty. Next patient is 84-year-old female, status was fall with left femoral neck fracture. Sorry. The patient was taken to the OR for left hip hemiarthroplasty.
Andres, can I stop you for 1 second just to go back to your first case? And just to bring up the question, I know the patient was taking bisphosphonates, but how are you sure that that patient doesn't have a primary bone tumor?
Yes, so theoretically we could do MRI of these patients, but the patient has no history of tumor. She was otherwise evaluated for that, and she got peaking on the both sides. So we assume that this biphosphonates.
Andres, what type of hip fracture was that you did a hemi on the last case? What classification?
Patients, I think it's Garden 3. It looks like, valgus impacted or minimally displaced, but the patient is 84 and it's posteriorly displaced fracture. So we decided to proceed with hemiarthroplasty.
How would I know looking at those x-rays that there's displacement other than valgus? It looks like you have a lot of head there.
Yeah, but the head is rotated posteriorly.
So
we can see.
How would I know that looking at this X-ray?
Yeah, I agree. You need a lateral X-ray or down view or to see better. Next patient is 24-year-old female, status was MVC with right T-type acetabular fracture with posterior hip dislocation, as well as left non-displaced acetabular fracture. It's a fracture line through the anterior column, as well as bilateral pubic Ramy fracture on the left side. The patients also had laceration in the groin that was penetrating to the hip. So the patient was taken to the OR for right acetabulum OR IF and left hip IND. Next patient is 77-year-old male, status was fall with right distal femur fracture. The patient is taken to the OR for right femur open reduction and internal fixation. Next patient is 63-year-old female, status was fall with left ankle fracture dislocation. Patient was taken to the OR for left ankle open reduction and internal fixation. Thank you. That's all cases from Rubberwood.
Can someone at Robert Wood stop the screen sharing? Can you guys see our screen?
Yeah, we see it.
Yeah.
Jeremy.
So first case is a 24-year-old male, status post fall from a ladder with a right open distal radius fracture. Was provisionally splinted in the emergency department and then taken for an IND and X-fix. CT scan was obtained, showing significant comminution. X-rays in the office, in the clinic, sorry, showed continued dorsal displacement of the distal fragment. And so he was taken back to the OR for a removal of X-fix and a dorsal bridge plate.
How were you
So what
better
is that?
able to reduce the articular surface with that as compared to the X-fix?
So for the X-fix, our initial plan when we went back to the second time was to try to use the pins of the X-fix to get a reduction. Unfortunately, it was about 10 days out and we couldn't move it much. So we actually did a small open dorsal approach and just open reduced it and put the dorsal bridge plate on.
So,
What about the
so obviously, yeah, that's what I was going to say. Obviously, the patient has an ulnar neck/head fracture as well. The main fragment for the sigmoid notch on the radius doesn't look like it's reduced based on your first view on the left side. Did you see the sigmoid notch? Did you look for the sigmoid notch? And what was the patient's ulnar variance on the opposite side, let's say, because this guy's obviously very short now?
Yeah, so we tried to get to that piece, but we decided he didn't have a block to pronosupination, so we didn't go chasing it. It would have been a reasonable decision to look at the other side, but we did not get contralateral films.
So now you have to leave this on for 3 months, and you're saying the distal radial ulnar joint is reduced?
It does not look reduced. This is a 76-year-old male, status post fall with a left hip intertroch fracture. Was medically optimized and taken for a left hip intramedullary nail. This is a 58-year-old female that presented initially to the ED with a right Weber B ankle fracture that was stress negative. She was made weight bearing as tolerated in a cam boot. Of note, she has a significant medical history: CHF, CAD, CKD, peripheral artery disease. She also has diabetes. She was admitted to the hospital for 10 days for a CHF exacerbation. The day after she was discharged, she walked on it without her cam boot, fell again, and had a bimal fracture on that same side. So she was provisionally splinted and then taken the next day for a right ankle ORIF with 2 syndesmotic screws. This is a 46-year-old male, status post axe to the hand with a left index finger tuft fracture and nail bed injury. Removed the nail, did a nail bed repair, and splinted open the nail fold, and will follow up in the office. This is a 71-year-old female, status post fall with a right proximal humerus fracture. She was neurovascularly intact and made non-weight bearing in a sling.
Good morning. First patient's a 17-year-old female, status post MVC, who presented with this right humerus shaft fracture. Patient was neurovascularly intact, radial nerve was intact. Pre and post reduction, patient was placed in a coaptation splint. Next patient's a 23-year-old female, status post fall with a right elbow dislocation. Patient was neurovascularly intact and was reduced and placed in a posterior splint.
Did you test her stability after you closed reduced her?
I did, yeah. So she was stable in flexion and extension after about, once I got to about like 130 degrees, she was experiencing some pain and discomfort, but she was stable in terms of, valgus and varus instability. She was a little lax with valgus testing or valgus stress.
So did she have an old medial epicondyle injury?
Yeah, so she previously dislocated when she was about 14 years old, and there's actually old films in Synapse of that injury, and she had those same ossifications on those films as well.
So did she have impairment from age 14 to age 23?
No, she had no functional impairments with the elbow at that point.
Even though the medial epicondyle was so displaced?
Yeah, I mean, nothing that she mentioned.
Did she dislocate when she was 14 and have a medial epicondyle fracture, or just a medial epicondyle fracture?
She dislocated.
Dan, the calcification seen just lateral to the joint line. What do you think the origination of that calcification was?
So besides the medial epicondyle, I mean, I guess it could be.
No, I'm looking at the lateral side. First of all, do you think that's new or old?
Oh, that's definitely old. I mean, it's present on the old X-rays. I mean, it could be like an old avulsion injury from the prior dislocation.
Right, and if it was, would it avulse from the proximal or distal side, typically?
I believe it's proximal.
Yeah, I think so. I mean, that might be a long way for it to travel, or you could just get some calcification within the capsule there. But I think, like we mentioned, there was obviously something not right with this elbow after the first injury.
Mm-hmm. Yeah,
It
agreed.
may not have been right, but she went 9 years with a terribly displaced non-union malunion and had no problems until this incident.
Yeah. All right. Next patient's a 6-year-old male, fell from the monkey bars, presented with the right both bone forearm fracture. Patient was neurovascularly intact, closed reduced, placed in a sugar tongue splint. Next patient's a 13-year-old male, status post fall with the left saltaris 2 distal radius fracture. Patient was neurovascularly intact, closed reduced, placed in a sugar tongue splint. Next patient's a 26-year-old female who fell about 10 days before coming to the ED. Came because of persistent pain, presented with this left distal radius fracture. Patient was closed reduced and placed into a sugar tongue splint. Next patient's a 96-year-old female, status post fall with the right distal radius fracture and left hip intertrochanteric fracture. The wrist was closed reduced and placed in this sugar tongue splint and will be managed non-operatively. Of note, the patient does have significant dementia and functional impairment. These are the left hip intertrochanteric films. Patient was taken to the operating room for a left hip intramedullary nail. Thank you.
You know, that first wrist fracture in the young person had an ulnar styloid fracture through the base, which is a bit concerning and worrisome, and how you're going to treat it. So that you got to be careful. I don't know that I'd put that in a sure arm splint. The old lady that's 90 something years old, it almost doesn't matter what you do with her. But this is a very proximal ulnar styloid, so probably involves some of the TFCC.
Thank you.
All right, more first patient's a 36-year-old male, status was MCC with a left closed tibial shaft fracture and also had a contralateral right ankle arthrotomy. He was taken to the OR for a washout of the right side and then in a left tibial intramedullary nail. Next patient's 89-year-old male, status was fall, presented with the left hip intertrope fracture. Was medically optimized and take the OR for a left hip nail. The next patient's a young female goalie, had a soccer injury, presented with a left small finger proximal phalanx injury. Further CAT scans obtained to further delineate her injury pattern, showing the impaction and displacement. She was taken to the operating room for a closed reduction percutaneous pinning. Next patient is a 62-year-old man, right-hand dominant, who fell off a ladder, presented with the left paralytic dislocation. He was neurovascularly intact. He underwent a closed reduction, and then he's taken to the operating room for an open reduction, internal fixation, and repair of his scapholunate using suture anchor.
Where did the scapholunate ligament come off?
So it was actually pretty interesting. You know, it actually avulsed off the lunate.
And the reduction you did was really good. Can you explain why, after reducing the perilunate dislocation, why you then opened it up?
Yeah, so you have ligament disruptions of your sacral dorsally and then your lunotricutal volarly, and even if you have an excellent reduction in the splint, those ligaments are disrupted and the position will not maintain over time. So since you're not unable to kind of maintain that position, those ligaments are disrupted, it's not going to heal down. So as a result, you need to open and repair ligaments and fix it in place in order to get the best result, so it'll scar down and heal and not have instability.
Well, that's mostly right. So you reduced the perilunate dislocation, and that was very easy. The problem is you're left with an intercarpal instability if all those ligaments are torn. And even if it's perfect initially, there's nothing hold. It's almost impossible to hold. So the likelihood is the intercarpal instability will persist. So if you can pin it closed, which is almost impossible, that's fine. But you're opening it to pin the carpus anatomically, and whether or not you fix the ligaments, that's up to you. I don't know that it's clear that fixing them is any different than not fixing them, as long as you pin the joints for 2 or 3 months.
Okay, I think we're done here.
Thank you.
No more present. That's it. Everyone's done.
That's it.
All right, great. Hold on, Jomar's got a case. Jomar, you're logging on, right? You're muted, Jomar.
Good morning, everyone. The first case is a 97-year-old female, status was ground fall, this left proximal humerus fracture. She was made non-weight bearing in a sling. Next is a 73-year-old male with this RCC, with a history of RCC with this right pathological proximal humerus fracture. This placement was made non-weight bearing in a sling, and will follow up as an outpatient to discuss surgical management.
What would you do for that?
RCC, notoriously not responsive to radiation therapy. So if we are sure that this is an RCC, which his cancer was he had a nephrectomy back in 2019, and it's sort of a smoking gun. He has a few lesions there, not just he has that one solitary lesion. I think that resection and reconstruction is the gold standard for him. Yeah.
Reconstruction, what are you talking about?
Sure. Yeah, I mean, like a total shoulder, like a replacement. So,
well, a total shoulder or reverse shoulder, or
well, it all depends on the cuff, which there's no thought that this one is out, so he could have a total, just a normal total anatomic total shoulder.
Right, but are you taking the whole proximal piece off?
Yeah, I mean, we'd remove the humerus. I don't know if there's, just remove the humeral head, and so you could probably just have a hemi even.
What are you trying to do for the patient? I mean, you described his history, right? He's got renal cell carcinoma. You're saying this is the only solitary met right now?
That's the only solitary met. Yep.
So sometimes are you trying to treat this as a cure kind of case, or just is it palliative care?
If you resect it, and if you remove and resect it and reconstruct it, it'd be a curative. It'd be the goal, at least.
Right. So when you think about the anatomy that you're removing to do that type of procedure, then that's, a hemi's probably not really going to solve the problem. Think about your margin of resection, right? I think that's what Dr. Kirschenbaum's getting at.
Gotcha.
Anybody from Sloan have any ideas what the guys who went to Sloan, who's left? Oh, the residents already bailed. They're gone. You're on your own, Joe Mark.
Happens. Next is an 18-year-old female, that's plus MVC. She had this L1 compression fracture. She was tender to palpation when I arrived, which resolved with Tylenol. The patient was neurovascularly intact. She left the hospital as weight bearing is tolerated. She'll follow up in the office. We'll treat non-operatively. Next is a 50-year-old male. Stats was a fight. This ulna shaft fracture in his fourth and fifth metacarpal base. He said he sustained the injury 3 days ago. 3 days prior, callus around ulna would say otherwise. He may have re-injured this, and so I placed him in a sugar tongue splint for the ulna and the hand. And that's it for me. Thank you.
One more presentation. Go Ryan Shear.
Good morning. First case is an 11-year-old female, right hand dominant. She was involved in an MVC. She was found to have a right proximal humerus fracture. She had multiple neurological injuries, including a TBI, suspected DAI as well. She was unexaminable. The injury was a week old when we were consulted. She was provided a sling.
Why did they get a CAT scan?
The CAT scan was a typical trauma, chest, abdomen, pelvis CAT scan. She was a trauma alpha 5 days prior to us being
Okay.
consulted.
Ryan, what's the purpose of the sling? She's comatose. Why do you have to put a sling on her in the ICU?
Well, we recommended a sling, given the intubation and sedation, the comatose status of the patient. No sling was actually ever placed on the patient. But if there was any rapid improvement in her status, that was our recommendation.
Well, the thing to remember in the ICU is there's going to be a lot of people taking care of her.
Yeah.
And if they don't recall that there's an injury there, now this injury is not going to display suddenly, but sometimes slings in the hospital and patients that are comatose are a reminder that there's something there. It reminds everybody to loop back on it every 3 or 4 weeks if the patient doesn't falls off your list or something like that.
Next case is a 80-year-old female, right hand dominant. She was a ground level fall. She was found to have a right proximal humerus fracture. She was neurovascularly intact, and she was provided a sling as well. Next case, 58-year-old male. He was a ground level fall. He was found to have a left inferior pubic rami fracture. The injury occurred 1 week prior to presentation. He was able to ambulate without difficulty. He just had some mild pain in the groin area on that side. He was made protective weight bearing with a walker. Next case is a 7-year-old female. She was a fall. We were consulted for a left ankle sprain. However, upon imaging, there was a question about a possible medial malfracture. On physical exam, the patient was she was neurovascularly intact. She had minimal tenderness at the medial mal site. She was able to ambulate basically without difficulty. So this to us looked like an os subtibiale, and she was given an air cast for comfort and allowed 2 weight bearers tolerated on that side.
What percentage of kids have an os subtibiale?
0.2 to 1% of the population.
Yeah, it's pretty low, but the incidence of actually having an accessory bone around the ankle or the foot is as high as 10%. The most common of those being the os trichome and the accessory navicular. But yeah, this is a common one. We see this all the time in the office, and you just use your physical exam skills to rule it out.
Good call.
Thank you. Next case, 11-year-old female. She was an MBC. She was found to have T10 to L1 superior end plate deformities or compression fractures. She was neurovascularly intact on physical exam. Her only complaint was moderate thoracolumbar tenderness. She had no other injuries. MRI was obtained to better classify the fracture and assess for any ligamentous injury, which was essentially absent. She was provided a TLSO brace for comfort and discharged from the hospital. That's it.
So I think she'll be fine, but you always worry if you had more than one compression fractures, especially at the thoracolumbar juncture. I would kind of keep a little bit of an eye on that, but I think she'll be fine.
Yes, sir.
The other point I would make on that one too is just, and I know she had it, but make sure that you're examining the entire spine. Anytime you have a documented spine fracture. Good clinical exam and then low threshold. I think if they have a distracting injury of imaging, cervical, thoracic, lumbar spine.
So she actually received CT pelvis at an outside hospital, and then she was scanned here with a CT cervical spine. So there was incomplete CAT scan imaging of the entire spine. So we acquired MRIs of the CT and Ls.
All right, that's all. Thank you.
Happy New Year, everybody.
New Year.
Thank you.